Welcome, everybody. My name is Kimberly Doris, and I'm the Executive Director and CEO of the Graves' Disease and Thyroid Foundation. We're a nonprofit organization dedicated to providing information and support for patients and caregivers. Today's webinar is Dealing with Thyroid Eye Disease, Patient and Physician Perspectives. A quick note that you will also hear the acronym TED or TED in place of thyroid eye disease. Our program today was made possible with a grant from the County of San Diego's Community Enhancement Program. This was originally intended to be an in-person patient education event in San Diego, but then 2020 happened. The good news is that we have an excellent virtual program planned for you today. Our moderator will be Dr. Don O. Kikkawa. He serves as Professor of Clinical Ophthalmology, Chief of the Division of Ophthalmic, Plastic, and Reconstructive Surgery, and Vice Chairman at the University of California at San Diego Department of Ophthalmology and UCSD Shiley Eye Institute in La Jolla. He is also co-director of the UCSD Thyroid Eye Center and a former program director of UCSD's Ophthalmology Residency. And with that, I'll turn it over to Dr. Kikkawa.
Thank you, Kimberly. I'd like to, on behalf of the faculty and all of our patients, thank the Graves' Disease and Thyroid Foundation for sponsoring this symposium. We have a very distinguished panel who will be speaking today, and we also have a special guest. The program is going to be a series of 15-minute talks. We'll start with our special guest, and then we have three talks by our distinguished panel, and then we'll end with a question and answer period. So with that being said, I'd like to introduce our first distinguished guest. His name is Carl. Carl has been a patient of mine for several years, and he's very graciously giving of his time to share his experience of what he's been through. And again, everyone's experience with thyroid eye disease is unique and different to them. So what Carl shares may not be broadly generalized to everybody, but certainly it's his experience. So welcome, Carl, and thank you for waking up early to be with us.
Thank you.
So why don't we start maybe by telling us how you were first diagnosed with Graves' disease?
Well, about, I would say 15 years ago, I had Hashimoto's and I was taking Synthroid for a little while, probably about 2 years, and then all of a sudden things shifted a 180, and my thyroid went out of control, and it was just it was really difficult, and so I had a endocrinologist, Dr. Bailey, up in Escondido, diagnosed me as having Graves' disease.
So that's a little unusual, where you started hypothyroid and then became hyperthyroid. So that must have been tough for your daily functioning and your body to adapt to.
Yeah, the Graves' disease part was pretty scary, actually. I was having pretty severe symptoms, having to deal with being hot all the time. I couldn't drive more than half an hour without sweating, and you know, and my throat, I was very hoarse all the time, and just super hyper, and it was you know, it was pretty bad. So I took methimazole for a while, and that worked pretty good, but Dr. Bailey got concerned when I had a sore throat and said, look, let's just do iodine 131 treatment. And actually, when I did that, it got even worse, because they had to take me off the methimazole for a while, and it made the symptoms come back and become pretty serious. But then the thyroid, the iodine treatment worked after about 4 years ago, or about 4 years of after that. Everything seemed to level off, and I wasn't taking anything at all. And then eventually it kind of it became more hypo, and so now I take about 75 micrograms, or what is it, milligrams, whatever it is, of Synthroid. I've been taking that pretty steadily for quite a while.
Right. So your thyroid problems initially began about 15 years ago. When did your eyes become involved?
I think about 5 years ago. Actually, I completely forgot about the thyroid eye disease portion of it. Dr. Bailey had mentioned it, a couple times early on, and he checked my eyes early on, and he didn't see any problems, and I literally forgot about it. And then all of a sudden, I started noticing double vision, especially when I was fatigued, and I'm like, what the heck? Where did that come from? And it was pretty sudden. I would be having very difficult time with double vision. And then, so I think that's about when I went to Dr. Bailey again, and I think he referred me to you. I can't remember what we did at first as far as treatment. I think we just let it run its course and made sure that my thyroid was under control. And then eventually, went through that, I guess, a symptomatic, what do you call it? The curve.
Right.
And then came back down. And that's when you and I think when I first met you, it had already come down quite a bit, but it hadn't really leveled off yet.
Right. I remember first seeing you, and you actually did have quite a bit of disease activity. Your eyes were swollen and puffy, and of course the double vision is also very troubling. How did you deal with the double vision?
I just tried to, the thing is, it was pretty hard. I just would be real conscious of it. And when I was driving or something, I would just, be careful, and I had to just deal with it. And I don't remember anything other than, bottom line was the most severe symptom I noticed was a lack of muscle control. So I couldn't, as you recall, I couldn't hardly look up at all. And I was having trouble looking to the right and to the left, and down wasn't too bad, but that was the most difficult part, I think. And then of course the bulging was an issue, but it wasn't that bad to me. I didn't really, that didn't bother me as much as the functional part of it.
Right. I remember when we first met, you were kind of in that active phase, and we talked about treatment options, and I think we did decide just to watch it very closely and see at some point where we could intervene.
Well, just if you wouldn't mind, at one point, remember, I did make an appointment. I was going to have the whole array of surgical treatment, but I chickened out and just waited.
Right. Well, we can talk a bit about that. You had some other symptoms, I think, that you mentioned to me. Double vision was obviously the most troubling to you, but you had some other things you were feeling and were experiencing. Yeah,
probably the next most important thing to me was the tearing didn't work right. Like my left eye was dry virtually all the time, and my right eye was dripping a lot. Like I'd be working and all of a sudden, I'm dripping tears out of my right eye onto my worksheet or whatever. And so that was a really interesting symptom. And then, by the way, another symptom that I didn't know was related to the thyroid eye disease was severe burning and itching. I thought it was just an allergy. And so I just, would take allergy medication. I forget what it's called, but the mild kind. And, I thought that would take care of it. And it never even literally occurred to me that it had anything to do with thyroid eye disease until I started the Tepezza treatment, because there was a worksheet they had and it said, what are you hoping, what are your symptoms? What are you experiencing? What are you hoping to get from the Tepezza? And I'm like, well, how about that burning and itching? So that was a really big deal for me.
Right. Was there ever a day before you had the treatment, was there ever a day where you didn't think or feel your eyes? I mean, it's something we take for granted that we have good vision and they don't bother us, but was there ever a day that you didn't think about your eyes?
No.
Well, let's fast forward a couple years. We did discuss surgery. This was probably several years ago, I think, when we did discuss it. Your eyes had kind of quieted down, and they were in what we call the inactive phase. And we discussed surgery, and as you pointed out, you did think about it and had scheduled, and then had some second thoughts.
Exactly. I was ready, and then thought, you know what, this is kind of scary for me. I'd rather just see how it goes and wait a little bit longer. And then, as you recall, just this January, I thought, well, you know what I'll do? I've got this swelling right in my, I don't know what you call this part of the eye, but right up by the nose, it's just a little bit more swollen. There might be some genetics there, I think, because my mom had that, but mine is more noticeable, I think. And so I thought, let me just, maybe I'll just go in and get the, get that done. And just, because I was kind of learning to live with the limited motion but just as an illustration, but limited motion, if I was looking in the mirror, I couldn't look above my forehead.
Right.
Without pain. Like right now, I couldn't look where I'm looking right now without pain. Right. And so, but I just dealt with it. I would just move my head. Right. And I didn't want the surgery.
But when you came in, a couple years later, after deciding, gee, I do want to do something about the eyelid part, we discussed the teprotumumab, which is the new FDA approved treatment for thyroid eye disease. And what were your thoughts at that time when we discussed that?
Well, there's a drug, I'm like, really? Okay, let's, well, does it work and whatever? And so you were saying that, it just had gone through the trials and everything. And I wasn't really at the peak of the clinical trial population. I was kind of past that. So we didn't really know what would happen. But my key thing was asking you about, well, functionally, does it make sense that it should help? And you said, yeah, it should. So, I thought, well, why not give it a try? And I, of course, checked out all the insurance and everything, and, found out that it would be covered. And so I, went for it.
And you're right. You were probably not the typical patient that the clinical trials treated, but you were still having symptoms. So we decided to go ahead and tell us what your experience has been.
Well, so I'm really happy with it. The very first treatment, I'd say within maybe the second treatment, I noticed a better range of motion of my eyes. I could see better in terms of, movement. I could move to the right and to the left and up and down much easier. That was the biggest thing I noticed, right? Almost immediately, I had better range of and freedom of movement of my eyes in all directions. Now, of course, it wasn't as good as it is now. It's, throughout the entire treatment, I think it got better and better. But like, I feel completely normal in terms of my eye movement today. And so that's been probably the most profound thing that I've noticed. Also, the tearing, actually the burning and itching went away day one. So maybe that was even more important to me. Both of those things sort of happened together, but the burning and itching and the eye movement, range of motion was much better right away, and then still is. The tearing part did seem to get better, and my left eye is not as dry as it used to be. I'm not having to constantly use eye drops. In fact, for quite some time, I wasn't even bothering with them. I just put them in my pocket all the time. But then I've noticed now that I'm still having to use the eye drops, so there may be a little regression there. And so I do notice less bulging as well. And that fatty tissue I mentioned, I think it's a little bit better, but I haven't really, that hasn't really gone away. I don't think the Tepezza had much effect on that.
Right. And any appreciable side effects that you experienced?
nothing that bothers me. I can tell you that the first thing I noticed was, because they mentioned some to look for, you know, in the literature. And the first thing was cramping a little bit. You know, your typical kind of athletic cramp you get in your calves. I got that about maybe every couple times a week, which I hadn't been having. So that would be one thing. Oh, I have tinnitus or tinnitus, however you pronounce it. I've had that since college, and it's been something I just deal with. But since I started the treatment, I don't know if it's because of that or it could be something else, but my tinnitus is a little bit louder, and it's in my left. I have kind of an unusual tinnitus, which happens to be a little bit more noticeable in my left ear than in my right ear. But it just I noticed it becoming a little bit worse recently. I don't know if that has anything to do with the Tepezza or not. And then what else? Oh, so this is interesting. This was actually what I call a side benefit. I used to snore a lot, and I had you know, pretty stuffy nasal passages like all the time. And since I started the Tepezza treatment, my wife commented, she says, "You're not snoring anymore at all." You know, and I'm like, what? And I noticed, like, I can breathe through my nose much better than I have been able to in 20 years. So that's, I think, directly related to the Tepezza. I don't know why, but it happened right when I started taking the Tepezza, and it's still, you know, I'm still good that way.
That's interesting. That you're right. That is one of those unintended benefits of the treatment. Well, we really want to thank you for sharing, Carl. Your journey and your experience is unique. And any last word of advice for other patients that are listening or watching this?
You know, I think if you get the opportunity, I would take the Tepezza treatment, and you know, I'd do it again for sure. And I think that, you know, I even might, you know, I want to talk to you later about the idea that, like, if there's some regression, you know, I wouldn't be opposed to doing it again. I didn't see any issues, you know, unless there's some long-term issues that you know, we discover.
Great. Well, thank you again, Carl, and we really appreciate you giving your time. And please stay on if during the question and answer period anything comes up, we might direct you a question or two towards you.
Okay.
So at this point, we're going to transition to our first panel speaker, Dr. Kyle Godfrey. Dr. Godfrey is the assistant professor and associate program director at Cornell University. He did his training with us in San Diego, and then he did fellowship in New York. And he's one of the experts in the area who treats thyroid eye disease. So Dr. Godfrey, please enlighten us on how age impacts thyroid eye disease.
Thank you, Dr. Kikkawa, and thank you, Kimberly, and to the foundation for the opportunity to speak and share some of my perspective today on this issue. I have no relevant financial disclosures related to this talk, and just a few questions to think about as we go through this are really how and does age affect thyroid eye disease, and how does this, you know, guide some of our treatment approaches? Also, how do we recognize what is active phase disease, something we heard Carl refer to in his experience, and how do we recognize this transition in patients of different ages? And finally, kind of a bonus topic that sort of ties in with something we heard from Carl is there a relationship between obstructive sleep apnea and thyroid eye disease? So we know that thyroid eye disease can cause inflammation and expansion of soft tissues around the eyes. This can present kind of clinically as bulging of the eyes, retraction of the eyelids, and double vision, as we heard from Carl. Dr. Nunnery, I believe, initially described sort of two phenotypes or two presentations of patients with thyroid disease. And those are patients like on the left, this is a CT image showing a cut through the eye socket. And this patient on the left demonstrates primarily orbital fat expansion. So you can see that black space that represents the fat, and the green arrow is expanded larger than the muscles, which are identified by the red arrows. In the right image, we see a patient who has more the what we call a type 2 picture, where the muscles are expanded more than the fat. And so this is, you know, has an impact on treatment, has an impact on patient presentation, and may be related in some capacity to age. So I'd like to start just by saying that while thyroid eye disease is different for every patient and everyone's individual experience is going to be very different, there are certainly factors that influence the disease, and we think that age is one of those factors. So broadly speaking, just kind of the big picture perspective, we think that eye muscle enlargement may increase with age, and inflammation tends to decrease at the ends of the spectrum, meaning the youngest and the oldest patients. So when we think about children, we tend to primarily see orbital fat expansion and less inflammatory signs and symptoms. Adults, on the other hand, sort of in the middle-aged adult category, tend to have both muscle and fat enlargement and may exhibit more of the classic inflammatory symptoms that we think about in thyroid eye disease. Older adults, more at the end of the age spectrum, primarily tend to have orbital muscle enlargement and also may exhibit less orbital inflammatory syndrome related to the disease. So starting kind of with young children, fortunately, thyroid eye disease is very rare in this group of people and often only has mild symptoms or maybe no symptoms at all. Children, again, tend to primarily demonstrate orbital fat expansion without muscle enlargement, which produces classical symptoms or phenotypes of proptosis or eye bulging and eyelid retraction or sort of opening of the eyes or more of that staring appearance. So those are kind of more classic and common features, whereas double vision and compressive optic neuropathy or vision loss from the optic nerve being squeezed is much, much less common in this age group. This was a study that sort of looked back over many pediatric thyroid eye disease studies over the years. We can see the most common symptom or finding in these young patients is this sort of lagophthalmos or eyelid retraction in which the eyes and eyelids are much more open. Proptosis or bulging of the eyes was also very common related to the fat expansion. But fortunately, in all of these series, optic neuropathy was not present. This was a more recent series from Dr. Katowitz at Children's Hospital of Pennsylvania, Children's Hospital of Philadelphia, rather. And these were all patients who underwent decompression. And so fortunately, we saw that children tend to have mild disease, and most will do very well with supportive care. If surgery is necessary, it can often be done successfully in what's called the stable phase, or the period when things are no longer changing. Of course, in this series, these were all patients who underwent surgery. So these patients all had proptosis. And the photo in the top right demonstrates sort of a classic patient in this demographic. Not much inflammation. The eyes are white and quiet, but just some bulging of the eyes, and also demonstrating eyelid retraction, which was the other common finding. And again, in these patients, we don't see much double vision or optic nerve compression and vision loss. So transitioning up from children, we know that overall thyroid eye disease severity probably increases with age. These are two studies from 1992 and 2006. This is something that people have looked at for many years. It's difficult to sort of quantify how severe overall any one person's disease is, and disease classifications have sort of changed with time. But these are a couple studies that showing basically severity and age are correlated. So as people get older, overall, their disease may tend to get worse. When we look at younger adults, similar to children, they tend to exhibit more orbital fat expansion without extraocular muscle enlargement. So this was a study this year from Dr. Dan Rubin and colleagues that was published in the European Journal of Ophthalmology, and looked at fat volume versus muscle volume as patients age, kind of looking across the eye spectrum in patients with thyroid eye disease. And they sort of identified that this younger cohort of patients tends to have primarily fat expansion. And this orbital fat increase tends to decline with patient age, whereas the eye muscle volume and the resultant double vision and compressive optic neuropathy findings may increase as patients get older. So when we kind of transition now to thinking about more middle-aged adults, patients in their 40s to 70s with severe thyroid eye disease, this is kind of the demographic we tend to see the most classic inflammatory symptoms. Things like redness of the eyelids, swelling of the eyelids, swelling of the conjunctiva or the skin that covers the eye, or the caruncle that we heard Carl refer to in his case. And sort of, again, these kind of tenderness, redness, swelling, things that are classically associated with inflammation and may respond very well to immune system modulation, things like corticosteroids, radiation treatment, or teprotumumab, which we'll hear more about later this morning. When we get to the oldest end of the age spectrum, patients kind of above 65 to 70 years of age with thyroid eye disease, these are patients in whom we tend to see more extraocular muscle enlargement or eye muscle enlargement and less orbital fat enlargement. This may be because the fibroblasts that are sort of at the center of this process have already differentiated and don't have the ability to become fat cells. And we also know in this group that double vision is very, very prominent. These patients are more likely to have preoperative double vision, meaning before decompression surgery. If they do undergo decompression surgery, they're more likely to get double vision after surgery. Surgical approaches also tend to be more conservative in this demographic, and they tend to maybe only have surgery on one side, whereas younger patients may undergo bilateral surgery. They also tend to be non-smokers. Either they've learned from experience that smoking probably isn't a great idea, or they've been selected for by some of the other adverse effects of smoking. I think in this demographic, it's very important to consider involving a strabismus or eye muscle specialist very early in the disease course to be involved and to help transition before and after surgery. So we know that, as Carl alluded to, there's sort of this active inflammatory phase when things are changing and progressive and dynamic. And over the course of about a year in most patients, this transitions into the more inactive, fibrotic, or quiescent phase. In the earlier active phase, we consider immunomodulatory therapies, things that kind of modify the immune response, radiation, steroids, teprotumumab. And in the inactive phase, we tend to treat patients with surgery. But it's not always obvious when patients may be transitioning from the active to the inactive phase. We certainly look at timeline and change in symptoms and things like that. But as you can see by the stars at the sort of the top of the curve, it can be difficult to tell if someone is over the hump and is improving or is still in the active phase. So to sort of answer this question as it relates to age, one of my fellowship preceptors, Dr. Michael Kazem, and I studied what it means and what it looks like to be active in patients of different ages. So we looked at 4 age cohorts, and we'll kind of talk about those, and basically looked at periods of disease activity versus periods of presumed disease inactivity. So in these groups, again, patients under 25 was the first cohort, 25 to 45, 45 to 65, and then 65 and above. We see that for patients with systemic thyroid eye disease in relation to their eye symptoms, in the older patients, this may be more temporally spaced, meaning they have systemic disease years before their eye disease occurs, whereas in younger patients, they tend to happen much closer together. We also saw that in the very youngest patients, the active duration of that active phase when things are changing and evolving may tend to be shorter than in sort of older and middle-aged patients. And again, in consistency with some of the other studies that we mentioned, we found that older patients tend to smoke less and younger patients tend to smoke more, which we know has a very important role in thyroid eye disease. When we sort of mapped the severity of these clinical features over time, we saw some interesting patterns. So again, going up on the curve is sort of the severity, and going across on the x-axis is time. And then we clustered these by color. So the darker colors are the older patients. So we look at some symptoms, and sort of for all patients, these things tend to improve with time. Things like fluctuation in their symptoms, pain with eye movement or pain at rest, and upper and lower eyelid swelling. For all ages, these tend to get better over time. Some features came out, like things like eyelid erythema or redness of the eyelids. You can see that sort of darker color curve. For most patients, while this may improve with time, for older patients, they may continue to have eye redness or eyelid redness well beyond the active phase of disease. So this isn't a reliable thing to look at when determining whether the disease is over. For something like eye bulging, for most patients, this bulging may persist beyond the active phase, but for some younger cohorts, this bulging may actually improve, and the resolution of the eye bulging may be a sign that the disease is resolving. And then finally, for some features, there was not really any great correlation between the active and the inactive phase, and not be something that's very helpful to look at when you're trying to determine if you're done with your disease course or not. So then taking a big step back, again, looking at kind of the time points at the very beginning of the disease versus when we think the disease may be done, there are a few reliable indicators in our study of things that may suggest active disease or disease that still has that significant inflammatory components. In the youngest patients, sort of the pediatric and young adult population, this may be eye bulging, eyelid redness, and symptom fluctuation. For the very oldest patients, those 65 and older, it may be limited just to upper eyelid swelling, meaning from their active phase to the inactive phase, the only thing that really resolves is that upper eyelid swelling. And then for the middle ages, sort of 25 to 65, we kind of tend to see those more classic inflammatory symptoms like redness and pain and tenderness that may kind of resolve and improve over the course of their active phase disease. So looking back at this topic as a whole, we know that thyroid eye disease looks and feels different for every person. And then among other factors, we now can see that age does affect how thyroid eye disease may look and behave for you. Age may accordingly influence what treatments that your physician chooses to proceed with, how closely they want to follow you, and what specialists they may also want to get involved in the course of your care. And the features that suggest active phase disease may vary with age. So I think in the last 1 to 2 minutes, I was asked to kind of touch on another topic of research interest to me, and that's does obstructive sleep apnea or OSA modify the risk and the severity of thyroid eye disease? So we know that thyroid eye disease and sleep apnea have overlapping systemic inflammatory mediators, meaning sort of circulating cytokines and other things that modulate immune system inflammation. and that some of these may have implications in thyroid eye disease as well as sleep apnea. So we did an initial study a few years ago. This was also done with one of Dr. Freitag's former fellows, Larissa Habib. And we looked basically at patients who have vision loss from compressive eye disease. And we found that these patients were more likely to be at high risk of obstructive sleep apnea based on screening with the stop-bang questionnaire. This basically asks 8 questions related to sleep apnea symptoms. And if you have a score of 3 or higher, you're considered to be at risk of sleep apnea. In a subsequent prospective study, we then basically every new patient that came into Dr. Kazem's practice, we offered screening with this stop-bang survey, and we followed them throughout the course of their active phase disease. I know the slide sort of has a lot of information, but basically everything that's highlighted in blue was significantly correlated with an elevated risk of obstructive sleep apnea or an elevated stop-bang score. So things like double vision, optic neuropathy, eyelid swelling, and redness. So overall, we do think that risk of obstructive sleep apnea is convincingly a risk factor for more severe thyroid eye disease and is something you should consider screening yourself for, perhaps at the beginning of your disease course or in conjunction with your physician. And we know that potentially, although we need future study, that sleep apnea itself may be a modifiable risk factor in thyroid eye disease. So I'll end there, and thank you again for the opportunity to present today.
Thank you very much, Dr. Godfrey. I think the sleep apnea connection is very important, and I think we'll have a little bit of discussion time for that. And I think given Carl's anecdotal experience with teprotumumab, it's certainly an interesting possible correlation. So thank you very much, Dr. Godfrey.
Thank you.
At this point, I'd like to introduce Dr. Suzanne Freitag. Dr. Freitag is professor of ophthalmology at Harvard Medical School. She's also chief of the Division of Oculoplastics. And welcome, Dr. Freitag. And Dr. Freitag will be speaking on teprotumumab for the treatment of thyroid eye disease.
Thank you so much, Kimberly and Don, for the opportunity to present this information today. And we've already touched on this with our patient who so specifically explained things that I'm sure prescribing doctors really could not, having gone through the experience himself. Let's advance my slides here. So I must disclose that I'm a consultant and on the advisory board for Horizon Therapeutics, which manufactures teprotumumab. So these are the eyes of many of thyroid patients. It's an extremely frustrating situation, of course, for patients to go through this. And up until this year, I found it extremely frustrating in a different way as a physician trying to help these patients. And we were always taught and always told our patients to have the expectation that things would not really get back to the way they were before this all happened. And it's really hard as a physician when almost a third of your patients have a condition like this that you really can't fix. But things have changed a lot. And so I'm really enthusiastic to discuss this in more detail. So I like to think about the signs and symptoms of thyroid eye disease and which of these our treatments can fix and which they can't. And so in order to go through this, I'll list them. So dry eye, as you've heard, is the most common symptom that people with thyroid eye disease experience, but proptosis or bulging eyes can occur, conjunctival redness and swelling, which we see in this example, the eyelids being open too wide, upper lids too high, lower lids too low, eyelids swelling and redness. This is literally a bag of fluid in this patient's lower eyelid. Patients can get elevated eye pressures, which is sort of like having glaucoma, pain behind the eyes, which can be very difficult to tolerate, incomplete eyelid closure, which we see up here, limited eye movements, which cause double vision, visual loss due to compressive optic neuropathy, which can be permanent unless it's properly and quickly addressed. Eyes prolapsing in front of the eyelids, sometimes even spontaneously, which becomes a social problem and a source of apprehension for patients. And then fatty deposits in the lids and behind the brows, as we see in this lower right picture. Every patient with thyroid eye disease has a unique constellation of these signs and symptoms. I've never met 2 thyroid eye disease patients who had the same issues. And the management prior to January of this year for mild disease was observation and comfort measures like eye drops. For moderate to severe disease, often we still just observed because we didn't have great options. When we needed to, oral or intravenous steroid could be used, or occasionally rituximab or other medicines as a second-line therapy. There are some doctors that believe that external beam radiation is helpful in certain patients. And then the surgical procedures of orbital decompression, strabismus surgery to relieve double vision, and eyelid surgery to help with all of the eyelid problems that people can develop. It's critical to understand which aspects of thyroid eye disease are affected by our treatments and which are not. So let's talk about steroid medication. Previously, this was our go-to medicine, whether it's IV or oral. This is the same list of symptoms I just showed you, but I've color-coded it, with green being likely to be fixed by steroid, yellow possibly fixed by steroid, and red not likely fixed by steroid. So steroid will fairly reliably improve the pain behind the eyes, the lid redness and swelling, and the white of the eye redness and swelling. Steroid might fix dry eyes, eyelid retraction, elevated eye pressure, and sometimes is enough to fix visual loss due to compressive optic neuropathy. But the other findings, like the bulging eyes, the incomplete closure, and the double vision, which are so bothersome to patients, are not necessarily fixed, even by the best medications that we had. But everything radically changed in January of this year. And that is because of the introduction of teprotumumab, or Tepezza. This is produced by Horizon Therapeutics and is the first and only FDA-approved drug for thyroid eye disease. This compound was a cancer drug. It didn't work for cancer as it was supposed to, but it was well tolerated by patients, and then it became repurposed for thyroid eye disease. So many humans have ingested this compound before it became a thyroid drug. It's a fully human monoclonal antibody. It inhibits insulin growth factor 1R and is indicated for the treatment of acute, moderate to severe thyroid eye disease. There's so much about the mechanisms of thyroid eye disease that we don't understand, that has been one of the challenges in developing a drug. We know about this piece of the puzzle, and so this drug was used. We know that autoantibodies activate the IGF-1R TSHR signaling complex in thyroid eye disease. This stimulates orbital fibroblasts. This results in inflammation and expansion of the orbital tissues, causing the problems that patients have. So the IGF-1R inhibitor teprotumumab blocks this. The drug is an infusion every 3 weeks for 8 doses. There are many logistical issues to getting this medication. For me, it's taken 6 to 9 months to get the new drug onto the hospital formulary, and this is typical of large academic centers. In the interim, we've been juggling a number of outpatient infusion centers for treatment of the patients. It's an extremely expensive drug, which requires an insurance authorization process. It's about $400,000 US for treatment of each patient. And this all requires significant office staff dedication for the entire process. I'm thinking of hiring a person just to manage all of this. It's so time consuming. The thyroid eye disease, as you know, has a time-limited course. The active disease lasts for 1 to 2 years on average, and then there's a chronic phase with reactivations possible but uncommon. Hence, a drug that can knock the disease into the inactive phase, we hope will have a good chance of long-term success. There's not a lot published in the medical literature currently on this drug because it's new. The phase 2 and 3 clinical trials were published in the New England Journal of Medicine and are quite interesting. I'll go into them in just a bit of detail. So this is the 2017 New England Journal phase 2. It's so similar to the phase 3 setup and outcomes that I will just go to the phase 3, which was published in the New England Journal in 2020. This all boils down to the bottom of the slide. There were 39 patients in the Tepezza group and 42 in the placebo group. So the trial compared drug to placebo. only. There were not any other variables, not comparing it to steroid, just placebo versus drug. And these were the prominent outcome measures: proptosis response, change in proptosis, double vision response, clinical activity score, overall response, and quality of life. In all areas, the drug was significant over the placebo. And this is a patient that was published, or two patients from the phase 3 publication. The top is a patient who received placebo, who did not have much improvement at the end of 24 weeks. And then the lower picture is a patient who received teprotumumab before and after. So we've talked about some of these side effects and safety issues with the drug. This is what's published. And I find that some of my patients are getting many of these and others are not seeming to be a big deal. Muscle spasms were the most common in the literature. I'm not finding it to be the most common in my patients, but as described, it's a pinch in the calf that most people are tolerating quite well. The alopecia, which means loss of hair, is described by the manufacturer as more of body hair rather than hair on one's head. And people who have thyroid eye disease, thyroid disease, can have changes in hair loss. And so how much of this is drug-related versus disease-related is a little hard to know. The most common thing I'm seeing in my patients is nausea and fatigue. It lasts a couple of days in most people after the infusion and is more common after the first few infusions rather than the later ones. We've also alluded to the change in hearing, and I'm noting what has already been said in my patients, where for patients who've had tinnitus before, they can have a little more of it. It often is in one ear, which seems interesting. And also a few patients have had some muffling of their hearing, described like water in their ears. And this is very mild, is often on just one side, and seems to resolve at the end of the treatment. Absolute contraindications at this point in time are pregnancy and breastfeeding. We are avoiding this drug in inflammatory bowel disease like Crohn's or ulcerative colitis. We're being very careful in our diabetic patients. I have several diabetics on this medication. We've not run into problems yet, but we're watching them very closely. So what else is going on with regard to clinical trials and this medicine? Well, Horizon has 2 trials ongoing. One is looking at the dosing. Are the 8 doses required, or can we do less, or are there indications in some patients for more? And then there's a study of patients with chronic disease. And in this trial, my understanding is it's soon after the inactive phase, where things are no longer progressing and active, but patients are still having problems. So I'm always a big skeptic. And so this clinical trial data is all interesting and encouraging, but I did not want to pass judgment on this drug until I used it in my own patients in my real world. So my experience so far as of yesterday, I have 44 patients signed up to receive this medication. The age range is broad, 22 to 80 years. The mean is 58 years. It seems like the patients are a little bit older than I expected in this age, collection of patients. There are 32 women and 12 men. I am prescribing and managing this drug myself. Many of the biologics, as eye doctors, we depend on primary care doctors or endocrine doctors or rheumatologists to prescribe. But this one is seemingly manageable, and I'm happy to be controlling the medicines that my patients are getting. So if you're going to get this medicine, I check a blood sugar and a hemoglobin A1C, which is an average of your blood sugars over weeks, as a baseline test. And we offer our patients audiology baseline testing just because of some of the hearing problems that people have described in the clinical trials. I'm finding this to not be a big deal, and so I'm not sure that I will continue this baseline audiology testing. And then just before each infusion at the infusion facility, I'm requesting a finger stick to test the blood sugar and a urine pregnancy test if relevant. So I'd like to show you a patient. This is a 65-year-old woman who had Graves' disease diagnosed in 2009. treated with radioactive iodine, and then on levothyroxine. She's a very reliable patient, non-smoker, but she developed thyroid eye disease 10 years later at the end of 2019. Her recent labs show that her thyroid hormone levels are in range, but her antibodies are a bit elevated. She had slightly decreased vision in her left eye, like 2 lines on the eye chart, which she noticed. She had a decreased ability to see the color plates, which I'm showing you an example of. I'm sure many of you with eye problems have seen in her left eye. Her eye movements were not full on the left, resulting in double vision. And the Hertel measurement, which you can see the device here, this is not my patient, she measured 24 and 27, which is fairly prominent. Her baseline was probably in the mid-teens before her thyroid eye disease. She also noted some pain behind the eyes. So here's a photograph before she started any treatment. And you can see, especially in her lower lid, she has redness and swelling. And also the whites of her eyes have some redness and swelling. And this is her CAT scan. The muscles that move the eyes are in this area. And you can see here, they're quite enlarged compared with the more normal muscles. And things are getting quite crowded at the back of her left eye socket. And this is a visual field test, which many of my patients and others I'm sure watching today have taken. The little dots are normal, but the dark dots suggest that there's loss of vision. So her whole lower field of vision in one eye was decreasing. So most would agree that she needs some treatment. So we talked about all the options, and she chose to receive teprotumumab. And she had resolution of her double vision and the visual loss after her first dose. Here she is after 7 treatments. And again, her measurements of the prominence of the eyes were 24 and 27. She's now around 22. She's suntanned in this picture, so it's hard to compare the color of her skin, but the redness is gone. And in fact, she's almost getting hollow here in the lower lids compared with the fullness that was there previously. So I have personal experience treating patients with visual loss due to compressive optic neuropathy, as well as chronic long-term patients with residual severe disease. And of note, we've talked about this as well earlier today. These were not part of the published clinical trials. So this is sort of expanding the indications of usage of this medicine. Here's a patient I just recently started on Tepezza. She's 45. She had severe inactive disease 4 years ago and has been very stable since then. She has proptosis, prominent eyes. Her Hertel measurements were 28, which is very prominent. She did not want to have a decompression because she worried about double vision after the surgery, but she did have multiple eyelid surgeries, including tarsorrhaphies, where we stitched the outer corners of the lid shut to prevent her eyes from prolapsing in front of her lids. And here she is after just 2 treatments with a significant improvement already in the prominence of the eyes. And if you look at her upper lids and her brows, all that fullness that we see over here is starting to melt away. And when she touches it, she says it feels much softer to the touch. So this is really, really encouraging and exciting for her. And this was one of our craziest situations. So this lady, before treatment, had visual loss, massive swelling, redness. She really was miserable. And she just completed her treatment, and we took a photograph of her, and we were reminiscing and looking back at the initial photo. And we saw this in her chart, and she said, well, that's not me. You put the wrong patient photo in my chart. And I thought, oh boy. So I checked it out later, and here's her photo from that day. And I've covered the blue part of her eyes, the iris, but she has some interesting freckles on her iris. And I was able to match the freckles from her iris to confirm that this is indeed a photo of the same patient. She absolutely swore it was not her. So she's almost hollow in these areas where she was very full before. And even onto the cheek and up into the temple area, she looks significantly different after the medication. And so I'm really literally not recognizing some of my patients after their treatments. Their faces are thinner, especially in the area behind the brows here and the upper lids. And then, as I showed you, in the temple. So I think this is a whole paradigm shift in how we think about thyroid eye disease and facial changes. And I hope that actually by seeing the results of what this drug can do, perhaps we can take a step back and unravel some of the mechanisms of why this happens to patients. So thank you so much for your attention.
Thank you, Dr. Freitag. I really like the way you tied in the facial changes, and I think that's something that is new because we've never talked about changes outside the orbit and the periorbital tissues. So I look forward to a little bit more discussion about that in the discussion period. The next speaker is Dr. Bradford Lee. Dr. Lee is Assistant Professor of Ophthalmology at University of Miami at Bascom Palmer Eye Institute, and his practice is in Palm Beach. And as we know, not everyone may respond to medical therapy or is a candidate for medical therapy. So Dr. Lee will be discussing surgical options. Dr. Lee?
Thank you, Dr. Kikkawa, and thank you to Kim and the Graves' Disease and Thyroid Foundation. It's so important and so meaningful to be able to help organizations dedicated to helping patients with thyroid eye disease. And I'll be talking a little bit today about the surgical aspect after these wonderful talks and patient experiences about the medical experience with Tepezza. I have no relevant financial disclosures. So our goal today is really to focus on customized orbital decompression surgery, as well as aesthetic eyelid and facial procedures in thyroid eye disease. So after seeing these dramatic, miraculous improvements on medical therapy, it begs the question of, is surgery obsolete, and is there still a role for surgery in this disease? Or can all patients be treated with IV infusions and get better? Well, I think that disease severity may not always warrant medical treatment. With a cost of $300,000 to $400,000 per treatment for a drug like Tepezza, there's a threshold, and normally we don't treat patients with mild disease with this. It's typically indicated for moderate to severe disease. There can be some residual disfigurement. There can be dramatic improvement, but oftentimes things are not totally back to normal. There's definitely hurdles with insurance authorization, and from a cost effectiveness standpoint, we have to ask, can our health system afford to drop $400,000 on a treatment? And then finally, there can be contraindications to medical therapy, whether steroids or Tepezza or other things like diabetes and inflammatory bowel disease, patients who may want to start a family soon, and other things like that. And then finally, all of these medical therapies that reduce inflammation are for active inflammation for the most part. And some patients come to us having had thyroid eye disease many years ago, and they're ready for reconstruction, but they're no longer in that inflammatory phase where they're a candidate or a good candidate for immunosuppressive and anti-inflammatory medications. So I want to acknowledge and recognize the profound impact on our psychosocial condition that thyroid eye disease can have. Disfigurement of the eyes and face during prime years of someone's life, in their youth or in their middle age especially, can be particularly devastating. I can tell you from talking to many patients that it profoundly affects their sense of identity, their self-confidence. So many of my patients tell me, I just don't take photos anymore, and I don't feel like socializing as much. And I think this physical disfigurement combined with the discomfort, vision changes, and even treatment side effects all conspire to negatively affect our patients' mental health. So what is the psychology of reconstructive and aesthetic surgery? Well, oftentimes there's this profound desire to reclaim the pre-disease appearance and regain the normal appearance of the eyes and face. Thyroid eye disease projects various emotions, things like surprise, fear, anger, and that's not necessarily how patients feel on the inside, and certainly not the types of expressions that they hope to project. And so other types of surgical procedures can help to soften these and mitigate and transform this into a more relaxed and project more positive facial expressions. And then, in preparing this talk, I thought about it kind of like a mommy makeover for the eyes and face. If you think about a mommy makeover, which is a surgery that happens after someone may have given birth multiple times. They have everything gets stretched out and descended, and it's not quite what it used to be before pregnancy. The idea over here is that after all of this inflammation, the swelling, the fat bulging, this can certainly cause the similar types of changes, and patients are ready to do something oftentimes to try to refresh their appearance and get them back to their pre-disease state. So surgical rehabilitation, we typically pitch this as a three-step approach: orbital decompression, followed by strabismus surgery to fix the diplopia and align the eyes, and finally eyelid surgery. What I always tell patients is that many patients can skip certain steps, particularly, for example, if patients don't have pre-existing double vision or pre-existing muscle restriction, they oftentimes can skip the eye alignment surgery. And then sometimes the eyelid surgery can be combined with the orbital decompression surgery so that it's not such a drawn out process for surgical rehabilitation. This was a paper that Dr. Kikkawa published long ago, to the point that the orbital decompression surgery must be customized. I tell patients that if your eyes are 8 millimeters out further than they need to be, that's a very different operation in my practice than someone whose eyes only need to go back in by 2 millimeters. I can tell you that some orbital surgeons do the same orbital decompression surgery for everybody, regardless of how bulgy their eyes are. But I think that every patient needs to be individualized. Every surgery has to be individualized. And every surgeon has their different approach and algorithm. So this is a CT scan of a patient. And I like to talk about the eye as the orbit as being a house for your eye. So with thyroid eye disease, it pushes your eye out of the house. And our goal here is to get the eye back into the house. So there's various ways that you can do that. One is by doing a home expansion. And that's how we do an orbital decompression in terms of the bone. Here you see we can take down the inner wall of the eye socket and expand the eye socket into the nasal sinuses on the side. We can also remove parts of the floor of the eye socket to take advantage of this extra space down in the maxillary sinus. And then we can also work on the outer wall of the eye socket by sanding down this little triangle of bone here. Now, it's also relevant to talk about the surrounding anatomy. Now, here is the intracranial space where you have the brain. And you need to be careful and know what you're doing when you take down this wall, because you approach the skull base. And if you were to have an accidental injury or breakage of the skull base, you can have obviously complications, including infection, bleeding, or significant complications. Likewise, when doing the lateral wall of the eye socket, our goal is to remove this triangle of bone and get very close to, again, the intracranial space. Again, if you're not comfortable or not sure what you're doing, you could inadvertently cause an injury to the intracranial space. Now, I always also tell patients that not all orbital decompressions are created equal. And this is not like a manufactured product that you can go to any orbital surgeon and get the same decompression. I say that decompressing an eye socket can go from 0 to 100%. You can literally shave down just a minute fragment of bone or do a very partial decompression and then not get the intended full benefit of the surgery. Very oftentimes, if I see a patient who's had an inadequate decompression previously, what happens is that the bone has not been completely taken down and maybe only part of the desired space that you're trying to gain is achieved. This is an example of a patient who underwent decompression surgery. You can see over here that she had slight asymmetry between her two eyes, the left side being slightly more prominent. And this is after her surgery. You can see that just decompressing the eyes caused some improvement in her eyelid retraction. And you can see that the right side went in 3 millimeters and the left side went in 5 millimeters. Again, customizing the surgery for the patient. This was a patient who underwent 2-wall decompression on both sides. And again, you can see there's improvement in the upper and lower lid retraction as you get the eyes back into the socket. And this is another patient who was very asymmetric. You can see the right eye was much further out than the left. And so I did a 3-wall decompression on the right and a 2-wall decompression on the left, getting her in 7 millimeters and 4 millimeters respectively. Now there's also new technology that's being increasingly used in orbital decompression surgery. It's called 3D navigation. And what it does is give the surgeon the ability to intraoperatively navigate and figure out where they are in the eye socket in relation to the other structures. It's sort of like a GPS for the orbit, if you will. It's been used by ENT surgeons, neurosurgery, and orthopedics. And there's theoretical advantages for a more complete decompression, potentially faster and safer surgery. Now, the caveat here is that there is a complex calibration process. Things can sometimes lose their accuracy during the surgery, and it wasn't really designed for orbital surgery. It's being applied. So this is an example of a patient. I have used this technology before, and I'm actually giving some talks on it at our academy meeting, but you can intraoperatively determine just where you are in relation to the orbit. So here I'm showing how you can actually access a marrow space up above on the roof of the orbit. Now, traditionally, the orbital roof is not considered a wall that can be decompressed because we think of it being too close to the brain, but there's actually space that can be accessed and taken advantage of if you need to get a bigger decompression. Here you can see I'm placing my probe, confirming that I've carried the decompression all the way back to the apex of the eye socket. Here that I've drilled down the triangle of bone here, getting very close to the intracranial space. And again, confirming that I'm up here near the skull base. So the benefits beyond the improvement in the aesthetics and reduction of proptosis is that the eyelid retraction also gets better. There can be improvement in the dry eyes because your eyes are not so exposed anymore. You can get relief of that pressure and pain and headaches that are associated sometimes with bulging of the eyes. There's relief of the redness of the eyes and vascular congestion due to the tightness in the eye socket. And you can have potential benefits as well for glaucoma and double vision. Now I'm going to switch gears a little bit and talk about aesthetic adjuncts in thyroid eye disease, and 3 in particular: botulinum toxin injections, lower blepharoplasty with fat repositioning, and fat transfer to volumize the lower eyelids, temples, and cheeks. So botulinum toxin injections are very popular in the US. They relax facial muscles, and they can, and thyroid eye disease is known to cause these hyperdynamic frown lines over here. And there's about 7.7 million of these procedures being done every year just for cosmetics. And here you can see how in one of these ads from one of the companies, it can really soften the frown lines and also cause a little bit of what we call a chemical brow lift and give the eyes a more pleasing and relaxed appearance. Lower blepharoplasty with fat repositioning has to do with addressing the puffiness underneath the eyes. This is something that happens with age, but it can also happen, in a more extreme fashion with thyroid eye disease. So what we're doing here is not only removing some of this fat, but repositioning the fat down onto the cheek to bridge that double concavity. And in the surgical video here, you can see that I'm repositioning this fat from the orbit and draping it over the orbital rim, over the bone here, to smooth the contour. Again, in the diagram on the right, you can see how we're taking some of the orbital fat that's protruding and repositioning it down into the cheek. This is an example of a patient who underwent that type of procedure who does have thyroid eye disease. So she did not have any bony decompression. She only had a lower blepharoplasty with fat repositioning. And you can see that there's a smoothing of the lower lids. I also took out some of the extra skin and fat on the upper lids. Now, fat transfer for facial volumization is to address the regional fat atrophy and changes that can either happen with age or with the disease process or after surgery. It consists of harvesting fat via liposuction, processing it to purify it and improve the yield of the survival of the fat, and then finally transferring it to volumize the lower lids, cheeks, and temples. And this is a setup that I use. I create these syringes filled of purified fat, And this is a patient of mine who, is intraoperative after injection of the fat to the right side, but before injection of the fat to the left side. So I'll start with a case. This was a patient of mine who had thyroid eye disease, and this was her before, and this was after her eyes were transformed and her face are transformed by thyroid eye disease. Not only do you notice the bulging of the eyes, the prominent lower eyelid retraction, but you see this hollowing beneath the eyes, hollowing of the temples here, and changes in that fullness of her cheeks. So first we started with the orbital decompression and lower eyelid retraction surgery and got her to this. Now she did have some double vision, but it was good enough that she decided she didn't want to have strabismus surgery. And then you can see we sought to address a little bit of the drooping of the right eyelid. We also addressed the extra skin and fat on the upper lids and lower lids, and then sought to volumize the temporal hollowing, the lower lid hollowing, and the cheek hollowing. And this is her after all of those procedures. And you can see that there's a smoother contour to the lower lids, the upper lids, the temples, and the cheeks. So both the disease and the surgery can really be transformative from the pre-disease state to the disease state and to the post-surgical state. One final case, this is a patient who had underwent multiple prior surgeries, 4 orbital decompressions, and 5 to 6 eyelid retraction repairs done at an academic center in the Northeast. She presented with interested in revisional surgery and bothered by the aesthetics of her eyes. And this is what her eyelids look like. You can see there's some residual proptosis of the eyes. There's lower lid retraction and this unusual shape to the outer corners of the eyes. There's this devolumization in her cheeks and down below. And she also noted that there's a bony contour defect. The way that the surgeon had done the surgery, there was a big notch in her orbital rim that was actually visible on both sides, and she was bothered by this. So I explained to her that having had so many surgeries, I wasn't keen about doing more incisional surgery because her blood supply had already been disrupted, there's scar tissue, and that what I really thought would help her would be to volumize the areas around the eyes to create that supportive platform for her eyes. We also talked about sharpening the angles, the outer corners of the eyes, and addressing those bony contour defects. And this is her intraoperatively after fat grafting the right side and before fat grafting the left side. And this is her after doing the fat transfer to the lower lids, outer canthi, and cheeks. And I apologize, she came from very far away. So I only saw her at 6 weeks after surgery when she still had just a little bit of swelling and was not totally done healing. But you can see that there's a smoothing of the contour of the lids and cheeks. It's not the eyes jumping out from a skeletonized platform. It's more harmonious, and no longer do you look at her and just see the eyes. So finally, I'd like to end with a few questions for you to ask your surgeon, and important considerations when choosing a surgeon. I think it's important to figure out what surgical subspecialties will be involved, both for your primary surgeon or any other surgeons they may want to get involved in your surgery. You should ask them, do they perform orbital surgery, eyelid surgery, and aesthetic surgery? Some surgeons only do orbital or endoscopic surgery in the sinuses. Some mainly have a medical eyelid practice, and some do medical, orbital, and aesthetic surgery. I was fortunate to have trained with Dr. Kikkawa, and he taught me all of the above, but it shouldn't be taken for granted. Then you can ask your surgeon, will their surgery be performed externally or endoscopically? Will they use navigation? I'd say, it really doesn't matter that much because you can have great outcomes with all of the above. And then finally, what is their algorithm and their order of walls to decompress? Like I told you, some surgeons treat patients like a cookie cutter approach, and they do the same surgery on every patient. But I think it's, the best results are obtained by customizing the decompression to the patient. You can ask them, how many millimeters do my eyes need to go in for me to have my ideal result? And in your hands, does your surgery reliably achieve this? And then finally, if you're interested, you can say, are there any aesthetic adjunctive procedures that I should consider? And the answer may be no, and the answer may be that, I would be happy just with a decompression. But for patients who are interested, sometimes you should ask this, because you may not have this addressed otherwise. Finally, thank you for your attention. Happy Halloween, and please feel free to email me if you have any questions.
Thank you very much, Dr. Lee. You showed some great results, and I'm sure all your patients have been very helped and pleased by the surgery you performed. At this time, I think we do have time for questions, and I have been answering the panel questions that have come up from the QA portion, but I would like to thank all of our patients for sending questions in to Kimberly. So we have some very commonly asked questions that I'm going to ask the panel. And the first one, I think I would like to ask Dr. Godfrey, are there any over-the-counter drops that you recommend for the dry eye that's associated with thyroid eye disease? And then what about prescription options such as the 2 FDA prescribed medications for dry eye?
Thanks, Dr. Kikkawa. Yeah, I think dry eye is certainly a very significant issue in this patient population, both from exposure and also probably from the primary disease process. I don't particularly have any brand allegiance. I think that, carboxymethylcellulose and the Celluvisc type drops tend to be a little bit more viscous and may be useful for patients with severe dry eye disease. And then I think there's a very important role for ointments and gel tears at bedtime for any patients who do have issues with incomplete eye closure. I think there's been several studies regarding your question about the other FDA approved drops. And I don't think things like Restasis have been shown to provide additional symptom relief beyond over-the-counter artificial tears. But I'd be curious to hear from the other panelists if anybody else has an alternative experience. But I think over-the-counter artificial tears are generally sufficient with the addition of either gel tears or lubricating ointment at bedtime.
Great, thank you. Dr. Freitag, do treatment options change if someone has inactive versus active disease? And I'm going to ask the second part of that question. Is there such thing as inactive thyroid eye disease?
I think we could write a whole textbook on what you've just asked. It's complicated and evolving. There have been some discussions since teprotumumab has been on the market among some of us who think about these things. We used to think it was more cut and dry of active versus inactive, but now we're realizing that patients who we would have called inactive previously are responding to teprotumumab, just similar in the way to people who we would have called inactive. So I think we're rethinking all of this. With regard to prescribing teprotumumab, I'm making less distinction amongst patients of inactive versus active because I'm looking at the problems that are bothering them and determining, as I showed on the list, are these things that the drug in question can fix. I'm finding it's not great at fixing upper eyelid retraction. It can, but it's not perfect. But I feel like most other things, it's helping quite significantly. Certainly surgically, I like to distinguish whether someone is active or inactive because I'd hate to perform a surgery like an orbital decompression or an eyelid surgery and then have the patient still progress and lose the benefit of the surgery that we did. So I think it really depends on the treatment and what your expectations are.
Great, thank you. This is one we maybe didn't speak so much about during this symposium thus far, and I might ask Carl to maybe weigh in on this one. Can you talk about thyroid eye disease and mental health issues? So we didn't touch on that, and Carl, maybe it would be worthwhile having you comment a little bit. How did this affect you from a mental and psychological perspective?
Well, I would say this, I do get a lot of personal exposure with clients and with mainly with, with of course friends and all that. And I never got comments like, wow, your eyes are bulging or any of that. Mine was never as severe as some of these pictures that we've seen, at least not that I recall. But there was, let's just say this, I've been videotaped doing interviews before. And then I look at the videotape and I'm like, wow, when I get excited, you know, my eyes really do bulge. And it affected me in that I would think about that when I would be, you know, doing an interview. And so that, you know, it had an impact. It caused me to think a little bit more about my eyes. And I think overall, just the idea that, you know, is this ever going to go away, you know, was a pretty profound, you know, issue for me. You know, I've had a number of ailments and there's usually some kind of fix. And the idea that this one isn't going to get fixed really is, you know, always on my mind. And, you know, it was just brought up, Dr. Freitag just mentioned, you know, how, you know, is there any inactive phase? And I realized in my case, I thought it was inactive. I thought it was stable, but obviously it wasn't, because the Tepezza treatment did have a significant impact on my eye disease.
Right. Well, thank you. Dr. Lee, you alluded to some mental health problems that patients have from a physician perspective. How do you deal with this in your practice? Patients come in that have this affect them on a psychological basis.
I mean, I think it's so important to recognize this and to acknowledge that is a very real and important aspect. I've heard patients tell me that, you know, I went to another surgeon and he told me, you know, you're not going blind from this. You don't need anything. You're fine. And they said, I'm not fine. You know, I'm a 25-year-old woman who is not married yet. I'm, you know, trying to meet someone. My eyes are disfigured and I'm not fine. And so I think it's really important to acknowledge that that's a normal feeling for many, many patients. And like I mentioned, you know, it's this combination of the pain and discomfort, the visual changes, the change in your appearance, and all of these going together can be extremely challenging for patients. Younger patients nowadays are also really into selfies and social media. And, you know, when you can't engage in that and you can't take pictures and do this, it's actually kind of challenging for the way that certain young people interact socially.
Right. I think one more thing I might add to your comments, Dr. Lee, is it doesn't only affect younger patients. We've had grandmothers that have come in and they say their grandkids don't want to come up to them anymore because they don't look the same and they look scary. So I think that it can affect patients at all ages.
I've certainly heard that from some of my patients in their 70s and 80s as well, who still very much care about their appearance. And sometimes it's the grandchildren who are the most disinhibited and tell you exactly what they're thinking. And that's what they've told me as well.
Great.
If I could add one thing, Dr. Kikkawa, that you taught me during my residency was sort of breaking down this stigma about it being cosmetic surgery, to Dr. Lee's point. And, you know, it's really not enhancing someone's appearance. It's trying to restore them, as you taught me, to their pre-disease state. And I think maybe just removing that stigma for some patients will allow them to feel more comfortable with proceeding with something that maybe isn't directly impacting their vision, but is designed to, again, restore them to what they were like before they were affected with this disease.
Right, that's an important point. I think from an insurance perspective, they may say, well, we're not going to cover this because it's cosmetic surgery, but this is a medical problem that's caused by medical disease, so we need to keep that as our basis of thinking. Dr. Godfrey, does radioactive iodine cause thyroid eye disease, and what's the relationship?
Radioactive iodine is certainly a well-established risk factor for inducing thyroid eye disease and certainly increasing the severity of thyroid eye disease in patients. I think it's important to consider alternative treatment modalities if you have active phase thyroid eye disease. And I think, you know, I kind of encourage all of our endocrinologists here at Cornell to send any patient they're considering for radioactive iodine prior to initiating treatment, but because there may be subtle findings suggestive of early active phase disease that might be appreciated by an ophthalmologist or an oculoplastic surgeon, but not necessarily by an endocrinologist. But I think depending on which studies you look at, it may increase the risk of progression or development of disease by as much as 5-fold. So I think, you know, treatments like methimazole, surgical thyroidectomy may be more appropriate in the active phase of disease. If for some reason, a patient maybe has mild or minimal sort of disease severity and does want to proceed with radioactive iodine, using prophylactic corticosteroids can be helpful in mitigating the risk. And different therapeutic regimens have been studied in terms of how much steroids for people to take. But I think the most recent studies kind of show that low dose steroids may be equally efficacious over a period of about 4 to 6 weeks during the therapy, and minimize that risk of a patient either progressing or developing thyroid eye disease from radioactive iodine treatment. But again, I probably wouldn't recommend it for someone in the active phase unless they didn't have other options.
Great, thank you. Dr. Freitag, is Tepezza effective for double vision with no bulging?
It can be. It's not 100% effective, of course, for double vision, but I think the bulging and the double are in some ways independent variables. I mean, they're all caused by enlargement of the fat or muscles behind the eye, but I would say, yes, it's possible. One thing I've noticed with double vision, some of my patients say, oh, my double vision is all gone and I'm doing so much better. But yet when you check their eye movements, they're not always full. But as long as the eyes are moving together, there's no double vision. So even if it's a little limited, going way far to the left and way far to the right, as long as the eyes move together synchronously, the double vision is better. So there's not always a full resolution of double vision. There's not always a full resolution of limited eye movements, but the answer is yes, it's possible.
And a follow-up question, if a patient, I think you presented a patient in your talk, if a patient has already had orbital decompression, can Tepezza still help with swelling and fat enlargement?
Yes, it can. So I have a couple of patients who a number of years ago went through the gamut, as some patients were presented today, of multiple decompression surgeries, multiple eyelid surgeries, and thought they were the best that we had the ability to get them. And they continue to come in every year for their annual exams. And we've talked about Tepezza and have started some of these patients on this medicine, and they are noticing improvements. So yes, it affects the tissues, perhaps similarly, whether there's been surgery to the area or not.
Great. This is probably going to have some difference of opinion from our panelists. So I'm going to start with Dr. Lee. How close can I get to my original appearance and vision after surgery and or Tepezza?
I think our goal is always to get patients to their pre-disease state. I mean, that question is, every patient is different. We have some patients who are very mildly affected, and those patients can very easily get back to their pre-disease state. On the other hand, we can have patients who their inflammatory phase is prolonged over years, and they can have recurrences, prolonged inflammation, especially if they're smokers. And these patients have a very difficult time getting back to their pre-disease state. However, I will say that, with medications like Tepezza, and thinking about it as a little bit more like a potentially chronic autoimmune condition, you can get the disease into remission and then consider doing surgery and still get pretty close. I think the most challenging patients to rehabilitate are the ones who have really bad muscle involvement, really difficulty moving their eyes, and those are the ones where it's difficult to get them eyes to move totally normally.
Great. Question about light sensitivity, and maybe we'll ask Carl to comment. This is a common symptom of thyroid eye disease, and I think you mentioned that you had light sensitivity. How did you deal with it when you had it?
I wear sunglasses a lot, but I mean, I never really felt like my eyes were abnormal in that way. I thought it was just because I have blue eyes, and blue-eyed folks tend to have more light sensitivity than others. So, that's never really been an issue for me.
Right. Dr. Godfrey, any comments? I think it's a common symptom that we hear, but as physicians, I think other than what Carl said, wear glasses. Do you have any other tips for patients with light sensitivity?
I think light sensitivity in thyroid eye disease is usually related to disease or dryness of the ocular surface, which can again happen for a variety of reasons. So I think a really good regimen of ocular surface lubrication with some of the drops I mentioned previously, lubricating ointments and gel tears at bedtime, and also really addressing if there's any issues with incomplete closure of the eyelid, especially in the evenings, things like moisture chambers, gently taping the eyes closed during sleep. Contact lenses and certain things can potentially be an option as well. But I think it's really about optimizing the health of the surface of the eye, and that can help a lot with the sensitivity to light. And there was one question in the panel about serum tears and what I thought about serum tears. I think serum tears are a great option. Certainly a few more steps involved in procuring, and basically involves taking some of your own blood plasma, processing it, and then using it sort of in an eye drop fashion. And it has certain trophic growth factors and things that stimulate regeneration of the ocular surface. So I think that's a great option that I neglected to mention earlier for patients with severe ocular surface symptoms.
Great.
Thank you. We've got time for one last question.
Okay. Why don't we ask Dr. Freitag, if there is a recurrence of hyperthyroidism, will my thyroid eye disease relapse as well?
There's no guarantee with thyroid disease about anything, really. It's an unpredictable disease that's not well understood, but the answer is yes, it's possible. When I talk to patients about what they can do to prevent recurrence of their active thyroid eye disease, the things we talk about are maintaining a euthyroid state. And so that can be done with medicines. If medicines are not controlling the thyroid well, to consider surgery, but it's not a direct correlation, but yes. And then the other important factor is smoking, which is something that can be difficult, but that patients can control to avoid smoking themselves, and also likely secondhand smoke can play a role in this.
Great. Well, before I turn the microphone back over to Kimberly, I want to thank our special guest, Carl, for sharing his experience and his time, and thank our panelists, Dr. Godfrey, Dr. Freitag, Dr. Lee. And special thanks to the Graves' Disease and Thyroid Foundation and Kimberly for allowing us to participate in this symposium.
Right. Thank you, Dr. Kikkawa. We received a lot of questions, and we tried to cover as many as we could, both in the Q&A and the questions that we got in advance. If your question did not get answered, please reach out to us at the Graves' Disease and Thyroid Foundation. You can see our contact information up on this slide. We're a patient group, and we won't give medical advice, but we can answer general questions or help you find the resources that you need. We can also get you connected with a support group. Right now, all of our support groups are virtual because of the risk of COVID-19. But even with that, there's still real value in connecting with people who truly understand what you're going through. So you can contact us toll-free in the USA and Canada at 877-643-3123. That's 877-643-3123. You can also reach out to us on social media. We're on Facebook, at Twitter. You can search for @GDATF. And we're also at onegravesvoice.com, which is a collaboration between the GDATF, Rare Life Solutions, and Horizon Therapeutics. And I will note that you've heard some discussion today about Tepezza, and the GDATF has received grant funding from Horizon Therapeutics for our patient education and support programs, but we do maintain complete independence with regard to all decisions on content. So many thanks to the County of San Diego, to our moderator, Dr. Don Kikkawa, to our presenters, Dr. Kyle Godfrey, Dr. Suzanne Freitag, and Dr. Bradford Lee, and to our special guest, Carl, for sharing his personal experience with thyroid eye disease. And thanks to you for spending a part of your day with us. Please stay safe and have a great day. Thanks so much.